Hello, everybody. Thank you for inviting me back to present to the group again. It's my pleasure to talk to you today about radiography of the spine. And this is the first of two successive lectures, and we will be talking about positioning and normal radiographic anatomy. What are we going to cover in this lecture? We are going to talk about indications for spinal radiography. When do we consider taking survey radiographs of the spine? We will then cover positioning and technique, and we will spend quite a bit of time there because good positioning and technique is crucial for appropriate decision making. Then we will talk about normal anatomy and some variations. And at the very end, I just have a few sneak peek examples of abnormalities. And of course, in the second lecture, we will talk much more about those. So survey radiographs of the spine, indications, applications, to get an initial overview. If this is a trauma case or if this is a dog that actually, has thoracic and abdominal images, but also has back pain, it just gives you a general idea if there's anything major going on when you look at the spine in those patients. This is probably not very commonly done anymore, but if you do myelography in your practice and spinal surgery for intervertebral disc disease, survey radiographs allow an educated guess. You also want this, if you're doing myelograms, to have an anatomic idea before you get started. How much subcutaneous fat is there? Are there any congenital anomalies of the spine that would prevent you from inserting the needle where you want to put it, and so forth. On many well-positioned survey radiographs, at least with extrusions, you can actually give a fairly accurate assessment what side is the most clinically significant one. Of course, you still need to follow it up. We also, at least in the past, used to take a lot of survey radiographs of the spine prior to deciding if we wanted to go to CT next or MR, just based on if we were seeing mineralized discs or not. Today, honestly, we skip that step, and in many cases with acute myelopathies, go to CT as the first-line imaging test. Assessment for instability, I put a question mark here. Of course, if you have a dog with suspected instability, if that is trauma or let's say atlantoaxial instability, you are going to look at that and be able to evaluate that. I would strongly advocate against stress views where you do positional radiographs to test for instability, and I will show you later why. Where radiographs are really most valuable is to look for obvious bony abnormalities and lesions like congenital anomalies, such as transitional vertebrae, inflammatory lesions of the bony structures like discospondylitis, trauma, for example, fractures, neoplastic disease, for example, primary bone tumors, and degenerative changes, which we see a lot and often incidentally, like spondylosis deformans. For technique, we always, well, almost always want to acquire lateral and ventrodorsal views. A possible exception may be, let's say, a trauma case and you see an obvious luxation on the initial radiograph you take. You may not want to maneuver the dog around, but in most instances, you're going to take two views. And the number of views really depends on the patient size and the body area. For the cervical spine, we aim for 1 to 2 lateral and VD views. In smaller animals, smaller dogs and cats, you usually can get away with a single lateral view. If you need a single lateral and VD view, if you need two views, either because the animal is very long or also to adjust technique factors, because the cranial neck is going to be thinner than the caudal neck, you want to center on like C1 to C4 and then C4 to T1 respectively. Similarly, for the thoracolumbar spine, it will depend on patient size and also the indication why you are taking spinal radiographs, but usually you want at least two and possibly up to four lateral and VD views, respectively, centered on the different body areas. And for the lumbosacral spine, usually you only need one, which is centered on the lumbosacral junction and cranial tail. The reason that you want to collimate to the area of interest and take several successive radiographs is that there is beam divergence just naturally. This is our X-ray tube. The plate or film is under the patient. This is the patient's spine with the vertebrae. And you see how in the periphery where the beam diverges, if you are not centered over the intervertebral disc spaces, you are going to get distortion, and the intervertebral disc spaces are going to look more narrow than they truly are. Now, that may not matter if you're looking for obvious bone tumors or something else, but if you are evaluating for intervertebral disc disease, disc space narrowing, trauma, for subluxations, this becomes important. So you want to move your tube or your patient that you have as many radiographs centered over fewer disc spaces as possible. Positioning, we are going to start with the neck. For the lateral views, you again want them as straight as possible, and that requires strong sedation. The animal cannot move, the animal has to be relaxed, the muscle cannot be tensed. At our institution, we do not hold animals for radiographs, everything is sedated. So to accomplish straight positioning, we might need wedges under the nose, under the neck. We use sandbags to put the legs out of the way and get the nose flat on the table. And what we want is a radiograph like the one on the bottom here. It's still not perfect, but you want the transverse wings of the atlas superimposed with each other and only see one of them. You want the transverse processes as closely superimposed as you can. So it's not the most perfect view you'll ever see, but I do believe this is about as good as you get in many animals. This one up here is completely unacceptable. You see the neck is kinked up, it's must be twisted to the side. You don't even see intervertebral disc spaces. It's severely oblique. So this is not going to be a diagnostic radiograph. Moving to the thoracolumbar spine, you want to collimate to the area of interest. And again, we want to take usually at least two, if not more, radiographs of the area of interest. Again, just showing you practically how this could look like with an animal sedated. We use, in this case, ropes to pull the legs forward. We use sandbags. We again use wedges under the thorax or abdomen to get the animals straight. These are very nice straight lateral views of the thoracic spine, centered on the thoracic spine, centered on the thoracolumbar junction, and then centered on the lumbar spine. So again, if everything works optimally, you want to see as many disc spaces as possible straight on. But even in this case, you see that some of those are beautifully hid with the tangential X-ray beam, while others are just a bit more distorted the further you go into the periphery of the X-ray beam. But these are otherwise good radiographs. For the thoracolumbar spine also, you want to make sure that they are straight and the rib heads of corresponding ribs are superimposed with each other and do not diverge, and that the wings of the ilium are superimposed with each other as well. So this is an example of a small breed dog, how we would potentially maneuver them to get them straight. We might need foam wedges either under the belly or under the back, depending on how the animal rolls. We use sandbags over the legs. We use ropes. And of course, you need strong sedation for any of these radiographs. So this is then what we would accomplish. This is very oblique. You see that there are the rib heads are not superimposed with each other. They diverge, and that really limits your ability to evaluate the spine. This again is not perfect, but it's better and was considered acceptable. At least the ribs are on the same levels, and you have a good view of the respective intervertebral disc spaces and vertebrae. These are radiographs of the lumbar spine, in this case, a cat. And you see this is too oblique. The wings or the pelvic portions are not superimposed with each other between the left and right. The transverse processes are not superimposed with each other. Now, if you're looking for an obvious bone tumor or something, this might suffice. But if you're really interested in optimized evaluation of the spine and the intervertebral disc spaces, you want a radiograph like this, where the iliac wings are beautifully superimposed, transverse processes are superimposed with the other side, and you see also the rib heads are perfectly at the same level. For the VD views, and I apologize, this was the only radiograph I had for that. For the cervical spine, we do want the legs pulled backward and the neck stretched out as much as we can. So the dog's head is down here. This is a sandbag. We use V troughs for VD views to accomplish straight positioning. What we do not want is a radiograph that looks like that. This is very oblique. You see the scapula is completely asymmetric. You see the atlas is completely asymmetric. Each vertebra looks just really abnormal. This is a straight view. We see the spinous processes superimposed with the middle of the respective vertebra, teardrop shape, very straight, and perfect symmetry between the wings of the atlas and the transverse processes. For the thoracolumbar spine, we typically pull the legs forward for that. And again, you can use V-shaped positioning devices. This is our V-trough at our institution. And we collimate to the area of interest, kind of in the middle of the dog, and trying to get them as straight as possible. These are very nice straight radiographs. Again, the spinous processes can be very helpful. If you have a straight VD view, you really don't see much of the sternum because it's going to be superimposed with the spine. If you see the sternum significantly overlapping with the heart on either side, then the dog is rotated and needs to be straightened out. And then for the lumbar spine, the same concept. You do evaluate best for your spinous processes, which should have a teardrop shape superimposed with the middle of the vertebra. And you also can look at the sacroiliac joints, which look very symmetric in this dog. These are examples of oblique positioning. So you see on the left side here, this is the thoracic spine notably rotated. You see the spinous processes are deviating to the right. You actually see the sternum. It's projected off to the left here. So this patient will have to be rotated so his sternum is shifted more towards the right. And then the radiograph was repeated and was much straighter. And now we have our spinous processes in the middle of the vertebrae. And then this is a lumbar spine in a cat. Not terrible, but also not great on the left side here with the spinous processes again being rotated and being superimposed with the vertebrae on this VD view. Technique. I did put an asterisk here because this probably was a bit more important with conventional hard copy films. Today, where everything is digital, we have a lot more flexibility and leeway. It's much more forgiving. But for good spinal radiographs, we want to use a bone technique. So we want a relatively low KVP with a higher MAS to highlight soft tissue differences and bony structures. We don't want everything to just look gray and gray. And depend on the patient size, but for most, especially larger dogs, we will need to use a grid technique to get rid of artifacts. So this is an example. Again, this was old hard copy films. digital radiography generally does better. But this was a high KVP technique, essentially a thorax technique without a grid. And you see how blurry it is, how poor the margination between bone and soft tissue is. Yeah, you see that there is spondylosis deformans, but otherwise this is really unacceptable quality versus a bone technique where we lowered the KVP, went up with the MIS and used a grid, and you see that this gives you much, much better bony detail. In addition to the spondylosis deformans, you see this curvilinear end plate defect here that's consistent with a Schmorl's node, that's a disc that's protruding into the vertebral end plates. Much, much better bone evaluation with a technique like this. So moving on to normal anatomy. The vertebral formula, you all know what the vertebral formula in dogs and cats should be. We should have 7 cervical vertebrae, 13 thoracic, 7 lumbar, and 3 sacral, and then a variable number of caudal vertebrae of the tail, dependent on the animal conformation. Realistically, and I do not have a good percentage for you, a lot of animals have abnormal vertebral formula. 12 thoracic vertebrae, 8 lumbar vertebrae, transitional vertebrae, 4 sacral vertebrae, uh, all variations all the time, usually incidental, but of course important if you're planning spinal surgery. When you look at the vertebrae anatomically, there are a few structures that are important and that we will also be looking for on our radiographs. So we have our vertebral bodies, and we will look at them on radiographs in a bit as well. The vertebrae are separate from each other by intervertebral discs, which on radiographs, because they are cartilaginous, at least in younger ages, will be more soft tissue opaque and will be loosened between the opaque vertebrae. We have several types of processes associated with our vertebrae, the transverse, the spinous. We will talk about a couple of others on the radiographs in a bit. And then just as a reminder, the vertebral canal lives dorsal to the vertebral bodies, ventral to the laminae, and contains the spinal cord with the meninges. And then the nerve roots exit the spinal cord and then the spine through the intervertebral foramina. I apologize how granular this is. Of course, this appears. I do not have a better copy of this, but it is a nice transverse image of a vertebra. And again, the ventral aspect is formed by what's called the body. Then the whole dorsal portion that kind of encircles the vertebral canal in the middle is made up of 2 pedicles, one on each side, and the dorsal lamina. And then there are several processes. The spinous processes, everybody knows about, they're important. Transverse processes, which vary quite significantly depending on what area of the spine you're looking at. They are different in the cervical, thoracic, and lumbar spine. And then we have accessory processes and also mammillary processes. And what I completely forgot are the articular processes, but we will see them in a moment on other images. But the articular processes form the articulation with the neighboring vertebrae, and we do see those on radiographs as well. I will show you in a moment. So these are 2 lateral views, one in a immature puppy and one in a mature dog. And in both of them, you appreciate that you have a vertebral body, forms the majority of the vertebra. When they are young, you do see open physis. They close 7, 8, 9 months of age, sometimes a little bit later. But in younger animals, you definitely see notable physis like elsewhere in the body. The physis separates the body from the end plate or epiphysis in young animals. We still call it the end plate in adult animals. It's the more opaque final portion of the vertebra that borders the intervertebral disc spaces. The intervertebral disc spaces are these loosened areas between end plates of adjacent vertebrae. The intervertebral foramina are these loosened regions superimposed with the more dorsal aspect and separated or separating the dorsal arches, pedicles and laminae of the adjacent vertebrae. And in dogs, the shape of the intervertebral foramina has been linked to horse heads or Snoopy heads or not Peanut, Woodstock, the bird in the Snoopy cartoons. Either way, it looks like a little head, maybe, if you put your thinking head on. And then we have the articular processes that also referred to as articular facets, and they articulate with each other in the dorsal aspect of the spine. And then we have various processes, as we said, that we will come to here in a moment. So looking at the cervical spine, this is a lateral view of a cervical spine in a dog. And what we are going to look closer at here is the cranial cervical spine that has some very unique features. So the atlas, the first cervical vertebra, C1, has two wide horizontal wings that on a lateral view are superimposed with each other. There is a foramen for the first cervical nerve here in the cranial aspect of C1 that is called the transverse foramen. This is actually a true completely closed foramen, unlike the later ones that are formed by successive or neighboring vertebrae. C2, the axis, has a very large spinous process that overlaps to some degree, usually 50% or more, with the dorsal arch of C1. And then there's also a dens associated with C2 at the cranial aspect, which you can appreciate here is actually hidden by the transverse processes, the wings of C1. Another thing that's important is that there's no disc at C1-2. The dens articulates with the atlas in the ventral aspect, but there's no intervertebral disc here. If you want to see the dens better, for example, you're thinking this is atlantoaxial instability and I want to evaluate if the dens is normally formed, you can do an oblique, slightly rotated view. This is a puppy and this is a straight radiograph. What you can do, and very carefully so, is rotate the head laterally maybe 10 degrees or so, so the bullae are not superimposed with each other. Note that this is not flexion. This is just a gentle rotation of the head, and this allows you to look into the vertebral canal and highlight the dens as seen here. Absolutely beautiful, very, very nice image, and definitely allows you a much better assessment of the dens than on this lateral view. We will come back to that obviously in the next lecture. But if you're looking for atlantoaxial instability, one thing you do want to look for is there a dens present, but also the distance between the atlas and the axis. So this here is a normal dog, other than having an intervertebral disc extrusion at C2-3, but we don't worry about this at the moment. But C1 and C2 are normal, and you see the overlap of the spinous process of C2 with C1 as it should be. This is a dog with atlantoaxial instability, and you see that there's a notable distance between the atlas and the axis with a very large size of the intervertebral foramen. So if you're worried about atlantoaxial instability, but your survey radiographs are equivocal, should you be doing stress views? And my very strong opinion is no. I would strongly advise against it. Stress views meaning should we flex the neck to demonstrate instability? So this is a Pekingese young dog puppy with neck pain, not walking after, that came in still ambulatory, but had neck pain, suspected atlantoaxial instability. Radiographs were taken and included the nice kind of laterally turned oblique view to visualize the dens. There is actually a dens. There's not a lot of overlap between C1 and C2, though. So this is a little bit equivocal, questionable. Is there atlantoaxial instability? And then, unfortunately, the decision was made to flex this dog's neck to demonstrate the subluxation instability here. And it widens up. What I would wager that if you do this in a normal dog, that gap is widening as well. So what is normal, what is abnormal on a flexion view, I don't even know. But what I know is that this dog was not walking anymore after the flexion radiographs were performed, which was very unfortunate. So it damaged the cord. And we got to do MRI at our institution. And I know we are not talking about MRI, but you see that this is the spinal cord has a significant signal alteration in the center. So in the flexion radiograph, it probably became unstable and it caused a marked contusion of the spinal cord at this level, which certainly should be avoided. So don't do that. Another thing to just point out, because sometimes it can be mistaken for anomalies or fractures, is we talked about the end plates and the physis. There is some peculiarity to the second cervical vertebra, sorry, the atlas axis, that has numerous separate centers of ossification. I don't actually remember, like 7 or so, but you see the dens here, which is actually quite large. There's a separate center of ossification cranial. So there is a line here. There's another line here. These are all normal physis. There's a line here. There's a line here. There's a line here. So this bone develops from a lot of separate centers of ossification. Not really, I think, important for us to remember the name of every single center, but knowing about it and knowing that this can be mistaken for fractures is important. If you're interested in learning all the names of these structures, you can essentially look up CT papers or normal CT anatomy, and it names them all, but it shows all the separate lines and ossification centers of the axis here. Moving to the caudal cervical spine normal anatomy, there are also some anatomic peculiarities. So C6, the sixth cervical vertebra, has, instead of normal transverse processes, has wide laminae that extend caudally and ventrally. They're perfectly superimposed on this radiograph, but there are 2 of them, one on each side. And C7 of the cervical vertebrae has the longest spinous process. This is before you hit the thoracic spine, where, of course, you have very long spinous processes. One thing to be familiar with is that C71 physiologically has a narrowed intervertebral disc space. This always looks more narrow than the others in the cervical spine. Not to be confused with an abnormality. And of course, we also at this level start seeing the first pair of ribs. This is a VD view of a normal cervical spine, and this is a close-up view of the cranial cervical spine. We are going to talk about a few anatomic features here as well, but I did also want to point out, and I didn't further label that, these thin loosened or opaque lines bordering this loosened area in the center. This sometimes gets mistaken for, I don't know, fracture lines, fissure lines, some abnormality. You need to be aware that the larynx and the cartilages and then the trachea are superimposed with this part of the spine, and the cartilages in those structures can potentially mineralize or be opaque and potentially be mistaken for an abnormality. So just be aware that you have your airways in the way here. Other anatomic structures we should be familiar with here are the wings of the atlas. Again, they extend to either side, and on a straight positioned radiograph, they're going to be very symmetric. The axis has the dens we already talked about, and you can actually see it as an anatomic structure separately in like on midline superimposed with the atlas. And then C2 has a very, very large spinous process that overlaps both with the entirety of C2, but then extends caudally over C3. And just as a reminder, again, there's no disk space at C1, 2. They are just articulating with the dens here. One thing I wanted to point out, so this is again the VD view I showed you on the first image. This is the dense normal structure. I wanted to point out this region of increased opacity, which is, apologies, which is normal. And the reason I wanted to point this out is that we, a little while ago, had a referral where in a practice, this was mistaken for trauma or a fracture, and the dog was referred in for this. This is normal seeing this line, and it is related to the fact that the very large spinous process of C2 overlaps with the cranial third of C3 and forms this region of increased opacity. So not abnormal, a normal anatomic finding. Moving down to the thoracic spine, the thoracic vertebrae have much larger spinous processes than the cervical spine. We do have our ribs, of course, and important to note that the rib heads articulate with the cranial aspect of the corresponding vertebra. So if we're looking at this T13 here, at the cranial aspect is where the 13th ribs come out. And then after that, we are entering the lumbar spine. So the thoracic vertebrae don't really have obvious transverse processes. They do have, of course, articular processes that articulate in the articular facet joints up here. One interesting feature of the thoracic spine is the spinous process angulation changing at the caudal aspect of the thoracic spine. So the spinous processes are kind of angled caudally up to the level of what is referred to as the anticlinal vertebra. It's usually T11, but it is somewhat variable. And then from the anticlinal vertebra caudally, they become angled cranially. Probably also not very important, but there is interestingly a paper that came out, well, it's almost been 20 years, but later than one would think, where they actually evaluated what radiographic definition do we give the anticlinal vertebra. And the only reason I'm mentioning this is we all have our probably perception of what we think of as the anticlinal vertebra. Is it when the spinous processes are perpendicular or spinous process is perpendicular, if it's vertical, oriented of the intervertebral joints? And depending on what definition you use, it changes which vertebra you would be calling anticlinal. I never thought about this being a problem at all, but it is probably because I always used the perpendicular to the long axis of the spine as my definition. I wasn't even aware that some people might be using other definitions. So just be aware that there are people maybe thinking in a slightly different way than you are. Either way, where the angle changes at this level here, level of T11, so at T1011 is where the orientation of the spinous processes changes. And what is important to know is that this intervertebral disc space tends to be narrow compared to its neighbors. So again, just a normal variation doesn't necessarily indicate intervertebral disc disease at this level. Moving on to the lumbar spine, there are a few interesting anatomic features here. The bodies of the lumbar vertebrae are longer than those of the thoracic vertebrae, and it's especially true for cats. So this is a lumbar spine of a dog, and yeah, the vertebrae are definitely longer than higher, so they look a bit more elongated than they do in the thoracic spine. In a cat, the lumbar vertebrae are really pretty. They are long and skinny and elegant, and kind of stretched out, so much longer than they are high. In the lumbar spine, the spinous processes dorsally are generally angled cranially, so they don't change anymore. And then we have transverse processes that are on this perfectly straight view superimposed between left and right, and they are directed laterally, cranially, and ventrally. There are some other processes. So there are so-called accessory processes that are present on the first lumbar vertebrae. Some references, it says the first four. I don't know that I always see them that well on radiographs there, though. They're also present on the last few thoracic vertebrae, but are hidden by the ribs on those. They can become clinically important because they are superimposed with the intervertebral foramina and they're very large in cats. So these are our accessory processes, and you see that they're somewhat variable size and shape. The major reason these are important is that they can be mistaken for abnormalities like mineralized disc material in the vertebral canal, disc extrusions, bone spurs, spondylosis, if one is not aware that these exist. But these are normal and should be recognized as such. On the VD view, we already talked about, we recognize a straight radiograph on the spinous processes being teardrop shape, elongated structures right over the middle of their corresponding vertebrae. The transverse processes also should be symmetric and extend cranially, ventrally, and cranially and ventrally. On this lateral view, you see them extending cranially. And then the articular processes that we already talked about that form the articular process joints. We have caudal articular processes extending from the respective vertebra and then cranial articular processes. And between those partners, they form the articular process joints, also referred to as articular facet joints. Same thing. An interesting feature, especially in larger dogs, is that the ventral margins of L3 and L4 may be somewhat poorly defined. So this is L3, this is L4. And if you look closely at the ventral margin of these vertebrae, they're somewhat poorly defined, somewhat lobular, somewhat less sharp than the cranial lumbar vertebrae. The reason is, even though we don't really think about it, but the diaphragmatic crura insert all the way back here. So they extend parallel with the spine and their muscle fibers extend all the way back here on the ventral aspect of the L3 and L4 vertebra. And with strain, it's essentially like enthesiophytes. You will see some remodeling here. It's really not intuitive and we don't think about it much that the diaphragm goes that far caudally. But when you think about what happens with inhaled grass awns, and you may or may not live in an area where that is a problem, but if animals inhale grass awns and they migrate and they form these sublumbar abscesses, they happen exactly here. And the reason is they go into the caudodorsal lung lobes and then migrate in the bronchi along the diaphragmatic crura all the way into the retroperitoneal space and end up here. So it's not something we commonly think about, but the diaphragmatic crura go very far caudal. For the lumbar spine, L7 is shorter than other lumbar vertebrae. And the lumbosacral junction and including the angle can be quite variable as a normal variation. There are really no good numbers here. So looking at this lateral view of a dog here and then a cat, the lumbosacral junction was considered normal. This dog actually had marked degenerative joint disease here of his articular process joint, but that was not important in this moment. But if you look at L7 and you draw like a line over the entire length, We do that in the cat as well. And then we draw a line of the same length over L6. You do see that L7 comes up short, more so in the cat. L7 is quite short in cats. The lumbosacral junction otherwise is quite variable. If you measured an angle, you would probably come up with something like 10-degree, 15-degree angle here, while in this cat it is very straight. The cat also only has like two fully fused sacral vertebra and a transitional vertebra. So this whole region is really quite variable in appearance. I'm not going to say much about this. We used to do a lot of flexion and extension radiography and myelography to look for subluxation with um, caudal lumbar spondylomyelopathy, cauda equina syndrome, degenerative lumbosacral stenosis. I At least here, this has really fallen out of favor. We do not do that anymore. I think it's pretty obvious just looking at this lateral view that there are degenerative changes and a pretty notable step between the vertebral canal at the caudal lumbar L7 here and the sacral vertebra. So this looks very abnormal even without the extension radiograph. So we don't do any stress views of the spine, period, nowhere. But I know some people still believe in them. This brings us to the most caudal aspect of the spine, the sacral and caudal spine, and those can vary quite significantly in their appearance. So in most animals, we do have three sacral vertebrae that are fused, although as you just saw in the cat, it may be incomplete ossification or only two sacral vertebrae or four when the first caudal vertebra is fused. Um, but what is probably more notable is with the increase in popularity of our bulldogs and other brachycephalic breeds, we do see a lot of screw tail malformations, sacrococcygeal malformations as incidental findings. Or can they be significant? Question mark. But we see many, many more animals these days that where the sacrum and tail look like this than we used to in the olden days. There is one thing I wanted to show you because it, I think, gets pretty frequently mistaken for an abnormality. When you look over the cranial aspect of the sacrum, where it superimposes with the ilium, at the lumbosacral junction here, there is this ill-defined area of increased opacity. And very frequently, people wonder, is this intervertebral disc mineralization? Is there mineralization in the intervertebral foramen? What is happening here? Is that spondylosis deformans? So that area often looks a little bit weird and not sharply defined, as if there was new bone formation happening. Keep in mind that the sacroiliac joints, which are quite large and round, superimpose exactly on this area. In fact, the sacrum, you only see the body of the sacrum here. On this lateral view, you really do not see the wing. The wing is probably corresponds to this circle here. And where it articulates with the ilium, this will be an area of ill-defined increased opacity superimposed here, and likely is the reason why this area often looks a little bit abnormal, even though it is not. Moving on to the tail, as we said earlier, the number of vertebrae in the tail is very variable, and the appearance of the tail is quite variable. One anatomic feature is of interest here, though, because it's also frequently mistaken for an abnormality, and those are these little bony protrusions on the tail vertebrae ventrally, seen both in dogs and cats. These are not spondylosis deformans. They're often called spondylosis deformans or degenerative changes. They are not. They are essentially vestigial residual structures from embryologic development, hemal arches from way back when we were all fish and we had dorsal neural arches and ventral hemal arches that contained our big blood vessels. Um, and the blood vessels were protected by a ventral spine called the hemal spine, which was juxtaposed to the neural spine, which protected the neural arch with the spinal cord. So these hemal arches, hemal canal residual structures are called hemal arches, and we still see them on the tail vertebrae to variable degrees. So this ends kind of the normal and technique lecture, but I wanted to end with just a sneak peek of a few abnormalities that we will be talking about in the next lecture to give you an idea how to approach a spinal radiograph and what abnormalities to look for. So we will talk about some congenital anomalies, and one thing we see extremely commonly are so-called transitional vertebrae. Those are vertebrae that exhibit features of the anatomic area cranial and caudal to them. So we can find them at the cervical thoracic junction, at the thoracolumbar junction, and also at the lumbosacral junction, where you see here there is sacralization of L7. Obviously, we have to know how many lumbar vertebrae there are to know that this is L7. Um, and where it articulates with S1, there's asymmetry, there's a transverse process on the left. It's not normal, but it's a little curvilinear transverse process, while on the right, there is communication with the sacral wing here and the iliosacral joint. Um, and the whole asymmetry at this level caused by this anatomic anomaly of L7 can potentially lead to uneven weight bearing, lameness, nerve root signatures, and hip dysplasia. But very, very commonly do we see this as incidental findings. Also, more so next week, we will talk about intervertebral disc disease and disc herniations, especially disc extrusions. So what we see with degenerative intervertebral disc disease, there's a mineralized disc in situ here at C4-5, but at C3-4, you also see a little bit of mineral material remaining within the intervertebral disc space, but the intervertebral disc space is narrow. The articular process joint space is narrowed compared to the caudal one, and there's ill-defined increased mineral opacity superimposed with the vertebral canal at this level, close-up view of it here, and then later on confirmed with the myelogram. These days we would go to CT or MR, dependent on the case. This is just a neat trauma case demonstrating the necessity of two views. This is a ventrodorsal view, and even knowing that there's something wrong, it's very hard to make out the anomaly. But on the lateral view, you see that there's complete luxation of the lumbosacral junction with cranioventral displacement of the sacrum, which actually overlaps with L7. Yeah, pretty bad. We will talk about inflammatory disorders. This is an example of discospondylitis, so infection, inflammation of the vertebral end plates with erosion of the end plates, resulting actually in some instability at this level with lumbosacral subluxation. We will talk more about that. And then we will also spend quite some time talking about spinal neoplasia. There are different types. There are primary bone tumors, there are metastases to the spine, and there are round cell tumors like multiple myeloma or lymphoma. And this is a nice example of multiple myeloma where you see numerous punched out lesions everywhere throughout the spine. This is just two images, cervical spine and centered on the thoracolumbar junction. And you see the punched out lytic lesions everywhere, kind of a hallmark of multiple myeloma. There's also obviously spondylosis deformans. So this is what I have for today as far as normal radiographic anatomy of the spine. technical tips, positioning. I hope you found this useful and a good starting point, and I'm looking forward to seeing you again to discuss some spinal anomalies. Have a good day. Thank you very much.